Hello everyone. Again, I've met some of you yesterday. My name is Nabila. I am a cardiologist. I work at London and I am here on behalf of the British Heart Valve Society, which is a society that I am counsel for, and we work very hard to try and spread awareness of heart valve disease. And we are a group of surgeons, interventionalists, physiologists, patient representatives and other scientists within the field who are very keen to advance the research in heart valve disease. So I'm going to be talking to you today about asymptomatic valve disease and what we do about managing that. But before I start, I just want to clarify for everyone in the room so that we're all on the same page. While we were listening to the previous talk, I thought I'd just do a quick visual diagram just to remind you, okay? Because I just wanted to make sure that all of us are aware of the kinds of cardiovascular disease that we face. So we have valve disease, which is what we're going to be talking about today. Valve disease mainly occurs in people over 65. Valve disease can lead to heart failure, okay? So that is a complication of valve disease. Coronary artery disease, the problem that leads to a heart attack, can happen at any age, but that can also lead to heart failure, okay? So both these different conditions can lead to heart failure. Coronary artery disease, the problem where people have blockages in the arteries and they have a heart attack, can happen at any age. And therefore heart failure, as a result of that, can happen at any age. Heart valve disease happens predominantly in people over 65, but they can get heart failure. So people who have heart failure can have heart failure at any age, but it depends on what caused it. So if the cause of one's heart failure is because of valve disease, primarily valve disease, it's more likely that that's picked up later on in life. But if the cause of people who have heart failure early on in their lives, so in their 30s, 40s, or even earlier, it's most likely to be a cause other than valve disease. Okay? So I just want to clarify that. And heart failure, just generally for us medical people too, is not really a diagnosis. Everyone has heart failure because of something. So when I see a patient with heart failure, I need to know what's caused it. Is it because you have valve disease? Is it because you've had a heart attack and now you've had heart failure? Or is it because you've got a heart muscle problem, so a cardiomyopathy, or a genetic problem that's then led you to heart failure? So heart failure is just a constellation of symptoms. It's not a diagnosis because there needs to be a cause. And that's what we do. As once someone has been told they have heart failure, we need to find the cause for it, and that's where we focus our treatments on. Okay, so hopefully that clarifies a lot of things. Okay, now going back onto my talk. So symptomatic heart valve disease is where people have symptoms. So classically, we think of the person with breathlessness, puffed out when they're doing usual activities, or swelling of their ankles, or collapsing, or getting chest pain. So these are the symptoms that we ask in any medical setting. But I'm not talking about that. I'm talking about the group of people who don't have those obvious symptoms, because I hope that if you were to have any of these, you would go and see someone and you would try to find out what's wrong. I'm talking about the people who do not have this, who have kind of vague symptoms that is difficult to find out what's caused it. So now, when we talk about valve disease, we're talking about primarily these three valves. Pulmonary valve, as was mentioned before, is usually a congenital problem picked up in young children, babies, and is a completely different spectrum. But aortic valve disease, mitral valve disease, and tricuspid valve disease are the valves that, as adult cardiologists, we try to address. So we tell our patients, or I tell my patients, make sure you let me know when you get breathless, or when you have a bit of chest tightness when you're doing something, or if you're feeling dizzy, or if you've collapsed. And those are the symptoms that we tell our patients who come back to see us regularly. Now, I'm an imaging cardiologist, so I see the patients before they have surgery. I look after patients all the way up until they need something done. So I'm going to be seeing them every year. Hi, Harry. Hi, John. Hi, Lisa. How are you? Do you have any of these problems? Your echo shows the valve is looking exactly the same as it did last year. If you're okay, I'll see you again next year. And that continues until they have symptoms. And so I tend to see the asymptomatic person, the person with less notable symptoms. But if you can see, these symptoms are very vague. We all get a bit of shortness of breath. Some people get ankle swelling now and then when it's hot, when they're on a plane. Some people get palpitations. So it's very difficult to be able to tease out what's because of heart problems and valve disease specifically, and whether we need to do something about it. So we need to be able to pick it up before it gets to the point of symptoms, because guidelines say that as soon as someone has symptoms with valve disease, that's when they need to have a procedure. So I need to be at that sweet spot where I'm picking up someone who it sounds like they have symptoms, and then I need to accelerate their progression through this pathway. So this is where early detection is important. We need to detect things so that we can get patients to that procedure in a timely manner. We know that if patients develop heart failure, we're too late. Yeah? They've already presented with symptoms. That means their heart has already changed because of their valve disease. So we need to get there in a timely manner. And we know that if we intervene at the right point, patients can have their normal life back to them. We also need to be able to manage subtle symptoms before they progress so that patients can have a better quality of life. They can maintain their activities and they can carry on as they want to. The longer we leave it, the more likely there'll be complications. Obviously, I mentioned heart failure, but there are rhythm problems that then will need other medications, anticoagulation, and all the risks that come along with that. So it's important in this group of patients, the asymptomatic valve disease patients, that we customize their treatment plan. And at that point, we have time. We need to allow patient education and awareness of their disease so that we can work together. So when the time comes for them to have surgery or percutaneous therapy, they know that this was coming, they know what they want, and they understand their risks. So how does early detection start? Well, I've done a lot of work in the community, and I'm not going to be talking about that here, but if you're interested, you can come and find me later. But early detection starts in the community. One US paper said that many patients presented first to their family doctor with symptoms of heart failure before they then went into hospital. So why wasn't it picked up then? That's because, number one, these symptoms are very vague. It could be for a number of reasons. Maybe the family doctor was going down a different angle and actually didn't think about heart valve disease, and that's where education and awareness comes into it. And detection starts in the GP practice. You come to see your doctor, you're over 65, and they listen to your heart. That's what needs to happen. So the GP needs to use their stethoscope and listen for a murmur. Now in the UK, we have murmur clinics. So not all centres do, but in a few centres in London, there are clinics where GPs can send patients who they've listened to and have found a murmur straight to the specialist so that that can be looked at in detail. Whether that's feasible in your countries, I'm not sure, but it's something to think about. But detection starts with the simple stethoscope, and that's what we need to do. We need to be able to listen to the heart for the murmur, and the murmur can tell us, is it aortic likely or is it mitral likely? But if they don't know, that's fine, because if there is a murmur, that needs to be looked into, okay? So we're trying to remove all the all the detail. We're trying to keep it simple so that we can pick up more and miss less. And then we need the echocardiogram, because we all know the gold standard to diagnose heart valve disease is using an echocardiogram. Okay, so that's what we need to get to. We need to get that patient from the stethoscope to the echocardiogram, because that's going to confirm it. And how are we going to do that? I would argue we should still be doing that in the community. Why do patients need to go into hospital for that scan when they can have that done locally, and they can be told locally, and treatments can be started, if need be, locally? But we won't talk about that now. And then once that echocardiogram has confirmed that they have valve disease, that's when the GP hands over that patient to the care of the specialists. That's when the patient comes to see me, and then we go through the rate of progression of their valve disease, their symptoms, their lifestyle, and in the asymptomatic patient, I need to be able to tease out, are they really asymptomatic? How many of you have seen your doctor and felt like that you've had enough time to talk about how you're feeling? It's difficult, but it's difficult from both sides. We're also limited with time. I'd like to really find out if someone is truly asymptomatic, because I'd like to know what their day looks like. Do you walk? Do you walk regularly? How long do you walk for? That walk that normally takes you 15 minutes that you used to do every day 6 months ago now takes you a lot longer, and you're stopping multiple times. But you wouldn't you wouldn't think to tell the doctor that, because you wouldn't think that's important, but that's important. Or what about when you're going to the gym, and you've been going to the gym regularly, and now you're getting a little bit of tightness in your throat, but you think, oh, it's probably a bit of heartburn, and it goes away very quickly, doctor, so I just carry on. So these are all real life examples, and I need to know those things so then I can trigger the relevant investigations afterwards. But it's time to be able to find out exactly what you as a patient, your life looks like. And then I can decide whether I think we need to take things further. But if you're truly asymptomatic, if you're fine, you're living your life normally, there's no problems, you don't get breathless, you don't get chest pain, you don't have swelling of your ankles, you don't have difficulty breathing when lying flat, then I'll see you in a year. And then we'll do the whole thing again. But if I do feel that you have, then you need to go down another cascade of investigations. One of them is a stress echocardiogram. And that is where we stress you. So we put you under exercise conditions, and we scan your heart at the same time to look at how bad that valve is. And we also check how your symptoms are. And if we can bring on symptoms with that test, that means you're symptomatic. You need surgery. If you can manage that and you're still fine, then that's fine. But we really need to be able to, as I mentioned, tease out those patients who are truly asymptomatic from the symptomatic. Perhaps you may need a CT to see how much calcification there is on your valve. There are other tests that need to be done. And then once we're there, it's a heart team discussion. We all need to sit down and talk about the lady who is 70, who now no longer walk, or look after her pets because she's breathless. But she lives alone. She doesn't really want to have big surgery because who would look after her in the recovery period? And she doesn't have many family nearby. There are so many factors that are individual to everyone that we need to consider. And that is where we all sit down with the surgeons, with the interventionists, with the nurses, and everyone who is going to help and know that patient to decide what the best thing the patient would require. The only thing that's missing is the patient, but we try and get a lot of the information from them in their consultations. So we try and say, what would you prefer? What's important to you? This is what the options are. And we'll talk about shared decision making a little bit later. Sorry. So now let's talk about aortic stenosis. And I know many of you have already heard quite a lot about aortic stenosis, and that's the kind of the most popular valve problem. We know some trials and ongoing trials say that if we actually do something with that valve before people have symptoms, they may have better outcomes. So in particular with aortic stenosis and aortic valve disease, intervening early before symptoms may actually yield better outcomes. But trials are still ongoing. You've seen these guidelines before, but without any jargon. If the patient is asymptomatic, so no symptoms, but their scan shows, their echo shows that their heart is starting to fail, automatically they need surgery. They need an intervention. They need something doing to their valve. If that patient is asymptomatic and then you exercise them and immediately they become short of breath, that's symptomatic, they need an intervention. And lastly, if they have an abnormal blood pressure response when they're exercising, normally when we exercise our blood pressure will go up, that's the normal change. But if our blood pressure goes down during exercise, that's an indication in the guidelines to have something done. So, patients who have no symptoms and are walking around fine, who have severe valve disease, need to have something done if they are showing signs of heart failure on their scan, if their exercise test shows that they then are very symptomatic, or if their blood pressure drops during the exercise test. Those are the three main things that we look for from the guidelines. For aortic regurgitation, so that's not aortic stenosis now, we're looking for signs on the echo of the heart dilating. That's a bad sign. If your heart starts to dilate as a result of your valve disease, that means that your heart is starting to change to try and make up for the demand, the stress that the valve is putting on it. And so that is a sign that someone needs something doing. So if they have any signs of heart failure from their scans, or if they have any symptoms, that is the reason to intervene. And so my job is to do those scans on those patients. When they come to see me, I do those scans. I make sure that there is no signs of heart failure or any signs of impairment of their heart function, and then I'm happy that they can go away. But if I find any of those, we're having the conversation sooner. I'm sorry, you're going to need something now. Now, in mitral regurgitation, again, it's a similar thing. Essentially, if your scan shows any problem with your heart, signs of heart failure, early heart failure, you need to have surgery or transcatheter therapy. Or if you have atrial fibrillation. So many people with mitral regurgitation have palpitations, and when they come to see me in clinic, they don't necessarily have breathlessness, they don't have chest pain, but they say, oh, I do feel my heart bobbling along sometimes, and I'm sure it's fine, doctor. No, I need to make sure that they don't have atrial fibrillation, because that is another criteria for an intervention. So then I send them for a monitor. Often, many people purchase the Cardia and they monitor themselves. But it's up to us as the physician to make sure that they do not satisfy the criteria before we let them go away for some time. And any signs of elevated lung pressures is also an important criteria, because if there are any signs of that, then they need an intervention. There have been several studies to try and find out whether actually intervening on the mitral valve early, before anyone has symptoms, is helpful. But there's been a mixture of outcomes. Some registry data shows that patients benefit from early surgery before any symptoms become apparent and before any signs of heart failure. But the opposite has also happened in some studies, where patients can't really take the stress of having surgery and they end up having complications. So we're still looking at trials, and we're still looking at evidence to support doing any of these interventions before symptoms or before signs of heart failure. Now, tricuspid regurgitation. The tricuspid valve has often been called the Cinderella valve because it's often forgotten about, purely because there isn't much in terms of therapies that have changed that we can do. Things are changing daily, but in terms of how things have evolved, the aortic valve therapies have revolutionized. Mitral valve therapies are now becoming more apparent. The tricuspid valve therapies, not so much. And so often tricuspid regurgitation is caused by left heart disease. So it's caused by other valve disease. And so we often worry about that rather than the tricuspid valve itself. Isolated tricuspid regurgitation isn't as common as you think. So the tricuspid valve, again, still lots of research required. There are some therapies, but we don't tend to intervene on it unless someone's having surgery for another reason and it's significant, or if their echo shows signs of heart failure from the right side of the heart. So this is the right heart now. And this is where we are for today. But as I mentioned, watch this space, because there's lots of things happening now with the tricuspid valve, and many centres are doing phenomenal things to try and see if they can fix and help those people who suffer significantly from tricuspid regurgitation. So I think it's important to make people aware of heart valve disease. It's really important that people know the differences behind heart valve disease, coronary artery disease, heart failure. That's what I do in my clinics often. I'll scan someone and patients will say, "Oh, well, my artery's okay, doctor." The echo doesn't show the arteries, it shows the heart function. And so it's about teaching people exactly what, and teaching them the terminology, and also allowing them to understand. I often do drawings in my clinics, to try and show and explain exactly what is going on. So people leave my room understanding a little bit more about their condition. Patients need to have more autonomy with their health and understand their body, as we mentioned before. Doctor, I'm a bit tired, but I wasn't like this 3 months ago. I was fine. That's important. A stethoscope check. Easy, simple, quick, can be done in the GP centre, no problem. Now, if there's concern about expertise, a digital stethoscope check, can that be done? Still, we're looking at the research. It is something that is coming, but I, as a clinician, have not seen any data that has told me that I can accurately rely on digital stethoscope data to diagnose valve disease. We're still doing a lot of work on that in the community, and it's still waiting to be validated. So it can definitely take away the human error for someone doing the stethoscope check. And I think everyone should be trying to push their physicians and everyone around to do the stethoscope check. The digital stethoscopes can be an alternative, and as I mentioned, I think that's a very good way to go forward, especially now as we have so many new diagnostic tools coming up. But it does not, I'm still yet to be bought on the accuracy of those. So I'm open to anyone if they have any data on that. And then I think we need to improve services outside of hospital for those who just need monitoring. If I had my way, everyone would be looked after in the community until they needed something done. We'd remove the need to go into hospital back and forth. They'd have their tests in the community. And for most of these cases, if it's just a matter of watchful waiting, they can do that in the community. They can have their scans every year in the community. And when it comes to that point that they need something doing, that's when they can be referred. But it's about bringing the expertise to the community. And that's where the problem is. We need more people knowing how to treat this in the community rather than preserving all the expertise in the hospital. I think that's my theory. So, okay, so my first patient, it's not real, obviously, but they've got severe aortic stenosis. And I scanned them in the clinic, and this is their left ventricle, working nicely. Walls are coming together, fine, quite happy. A year later, I scanned them. Oh dear, bit of weakness there. They now need something done, okay? So this patient has got heart failure, yep. This patient started off like this, but then over time, see how large that left ventricle has become? It's dilated. Oh, sorry. It's moving a bit strange. That patient needs something doing. So, in my assessments, these are the assessments that people go through every year to make sure that their heart isn't changing, the function of their heart isn't changing, or the chamber isn't dilating, or they're not experiencing symptoms. If they have either of those, they meet criteria for having something done. And I think that's it. I keep going the other way. Yeah, so just to conclude, it's important to really, if you're labeling someone as with no symptoms, they've got severe heart valve disease, but they have no symptoms, I need to be really sure that they have no symptoms. I need to have asked multiple questions. I need to have checked with exercise testing that they really do not have symptoms. And I need to have scanned their heart to make sure that their heart function is okay. That's when I can really label this person in their notes, asymptomatic severe heart valve disease. They need to be monitored regularly with regular consultations. I need to ask them, are you getting breathless? Are you finding it difficult lying flat? Are you using a few more pillows? Anyone recognize these questions? Yeah, are you using a few more pillows to sleep at night? All of these small things tell us something. Early intervention is generally better from recent trials for aortic valve disease, but for mitral and tricuspid, the jury is still out. Thank you.